I'm representing here the association, the European Association for Predictive, Preventive and Personalized Medicine, which has been created in Brussels in 2008. Nowadays we are the umbrella for 50 countries worldwide, and I'm going to explain you why so many P's, particularly in strategies regarding the breast cancer management. So the previous two speakers created an excellent platform actually for my talk. Thank you very much. I will refer to your talks and data in my presentation. In the previous year, we have already corrected the numbers of breast cancer patients. So worldwide, it is about 1.8 million and 450 million of deaths only for breast cancer. The numbers of our patients increasing, unfortunately, and it means that something wrong is going on in cancer treatment and prevention. Thank you very much for your help. So, as Carla already mentioned, and I told you that the problem is that increasing number of patients, particularly for breast and prostate, and it means that we should reconsider our long-term strategies in terms of how to predict the patients with breast cancer and how to target the preventive measures for that. Because we are in the context of personalized medicine, I would like to start with a case report. I'm not going to read the text, just to conclude what was wrong in this patient case. So it was a young woman, and unfortunately the diagnosis was provided in inverse sequence. So what we have overlooked is the symptomatic of headache. It was getting more and more frequent, followed by dizziness, and first we start to act in as the patient started to suffer from disturbed visual fields frequently over the day. So that's why we first diagnosed the metastasis in brain, and then started to look for original tumor, and it was very, very small tumor in breast. So I can tell you that this is unfortunately not a unique case, that at our radiological hospital we deal daily with these cases. That first we start to look for what is going on with headache and dizziness and visual field. And last patient I saw a couple of days ago, the girl 22 years old, full of metastasis in brain, and this was diagnosed first, and then we looked for the original tumor, and once more it was very few millimeter of breast cancer. So unfortunately this is the problem which we start to deal with. The next problem, and really the mystery of brain metastasis, we have published this phenomenon in 2017. Just to summarize the point, generally brain tumors are extremely rare disorder. But in contrast to this, in breast cancer patients, particularly some specific subgroups like triple negative breast cancer, develop up to 30% in the group the brain metastasis. It means that somehow this type of breast cancer opened the door for brain tumors, and currently we are not able to explain this phenomenon. We just deal with this, and it means once more that we should reconsider our strategies, that we are not first diagnose the metastasis in brain and then go to treat breast cancer. Specifically in the group of triple negative patients, as I said, up to 30% of them develop brain metastasis, and because of very aggressive type of tumor, approximately 50% of these patients die within 6 months of metastatic breast cancer diagnosis. So this is the second problem which we would like to draw your attention to. The next problem, also mentioned already quickly here, so-called pregnancy-associated breast cancer. Generally, a couple of years ago, the ratio was 1 to 15. Now we are talking about 1 to 3,000 of pregnancies. Generally, you can say, not too many. But if you consider that altogether worldwide we deal with approximately 250 million pregnancies, 250 million, and recalculate it for the number of cases, you will come to 80 to 100,000 new cases of pregnancy-associated breast cancer worldwide. It's not too small number, actually. The problem here is that mothers or pregnant women, in order to save the fetus, they refuse to undergo any treatment. And you know that during the pregnancy, a lot of a spectrum of growth factors are released. It means they're extremely supportive for the development of tumor. So 9 months without treatment, it is too long, and particularly in case of triple negative, and to this point I would like to say you that approximately 30% of pregnancy-associated breast cancer are triple negative cancers. So, and what we know about this subtype of cancer, that frequently they develop the cancer in parallel to metastatic disorder. So after 9 months to start to treat is definitely too late. And we are talking once more about 100,000 cases around the world. So going to the point about the age, still nowadays we consider that the majority of the cases are postmenopausal breast cancers, but we recognize new trends which demonstrate highly increasing prevalence of the premenopausal breast cancer with unknown etiology, unclear phenotype, such as triple negative and PABC. What does it mean for us concretely if it is unclear phenotype, unknown etiology, that in this case we have no appropriate screening programs, no prediction, no targeted prevention, and poor individual outcomes. This is the reality. That's why, coming back to many PPPM in the title of our association, what we would like to suggest is not to run behind the train, but to start to look for skills and develop instruments how to predict particularly aggressive breast cancer in the population. And then as soon as we are able to predict, and with high probability over 90%, of course the best case for us, we will be able to trigger the targeted prevention. Unfortunately, currently in the population, to predict and prevent premenopausal triple negative breast cancer, PABC, is more difficult than to look for a needle in the haystack. Why? Because we know the phenotype of haystack. We don't know the phenotype of triple negative breast cancer and PABC. So once more, to stress the point, we are not skilled to predict these subgroups in the population. What to do? So what are our strategies in terms of PPPM? So emerging tasks and corresponding strategies in breast cancer, PPPM. Definitely what we need is to analyze and to interpret current trends in breast cancer, and also for individuals at risk. We urgently need to go for phenotyping. Once more, we are absolutely unskilled looking for subgroups like triple negative breast cancer in the population. We don't know how they are looked out. Then, as soon as we learn more about phenotyping, we can move more for individualized patient profiles. This is, of course, about personalization in patient services. What is absolutely desirable is the predictive diagnostic, the best, of course, at the level of pre-lesions. Patient stratification, because still we have some golden standards and we apply to the subgroups, but we don't apply individually the algorithms. And definitely we are looking for innovative screening programs, particularly appropriate for triple negative breast cancer and PABC. as soon as we will be able to predict the diagnosis, to estimate the risk, we will be able to target the prevention, and at the end we can really talk about personalized treatment algorithms, not before that. So, as I told you, we are unskilled in terms of phenotype. So let us check what is going on in the society in terms of phenotyping. The talk by Carlo was very helpful for me because he talked already about obesity and diabetes type 2 as risk factors for breast cancer. And we know about that. So really obese women are predisposed more to breast cancer, and diabetes type 2 is really strong contributor towards this. We know about that, and we're working on this probably already 20, 30 years. That's why we are quite knowledgeable in this area. But still, because of the epidemic scale of diabetes mellitus, and now we are about to have 500 million patients worldwide, we still run behind the train. So we expect the strong increase of breast cancer related to obesity and diabetes in the society. What is the very first, talking about prediction and prevention, what is the very, very first step in the cascade of breast cancer and other types of cancer in diabetes? You know, we know about the retinopathy, we know about angiopathy, nephropathy, and so on, but the whole story, the whole cascade starts actually with microvascular disorder. This is very, very typical for breast cancer in obese persons. Okay, we know about that obesity is linked to microvascular disorder. We know that this is a risk factor for breast cancer. Probably we were too pushy in the past to say to our patient and to the population, lose your weight and you will be healthy. So a lot of teenagers followed these recommendations, and you know that a lot of girls, teenager age, try to be Barbie-like. So extremely low body mass index below 20. If you go for shopping, definitely you see more XXL and XXS in the in textile industry compared to normal sizes. But the question is, to be very slim means to be very healthy, particularly in terms of cancer and breast cancer. What we know too little now about this subgroup in the population, this XXS. Unfortunately, because it is quite new for us in the science and in the clinic. But what we have already recognized, that typical for this group is anorexia nervosa, depression, impaired wound healing, decreased immune barrier, reproductive dysfunction, decreased survival in cancer patients, and definitely once more, primary vascular dysregulation. So you remember that I said that vascular dysregulation is the trigger, the beginning of cancer problems with the subpopulation of obese and diabetic persons. Here we are not about XXL, we are about XXS, but we are coming to the same problem, vascular dysregulation, amongst others. This is to summarize what is going on. So on one side, we know that atherosclerosis, obesity, hypertonia, and so on are strong contributors to vascular dysregulation on one side. But on the other side, we deal with primary vascular dysregulation in very young population, low body mass index, physically active. You know, everything what we heard till now, actually excellent. It should be excellent, no risk factors for breast cancer. But we started with breast cancer a little bit later in this subpopulation. The very first recognition in this subpopulation was done by ophthalmologists. In Basel, the group of Professor Flammer, who demonstrated that very obese people and very slim people actually are coming at the end to the same pathology, namely glaucoma. So you know, everybody is working with the skills which you have. So radiologists are working with breast cancer, ophthalmologists are working with glaucoma. But it was very strong indication for us to look what is going on with this subpopulation in our area. And what we found, that so first of all, the phenotype of this very slim population, so-called Flammer syndrome, they have frequently cold hands and feet. Frequently, they have altered reaction of blood vessels towards stimuli, stress stimuli called provocation and emotional stress. They demonstrate frequently a low blood pressure, prolonged sleep onset time, reduced feeling of thirst, increased sensitivity to pain, vibration, and so on. So it is very, very clearly described phenotype which we deal with here. And the pathologies which have been linked till now is quite a long list of them. Comprises venous occlusion, hemorrhage, normal tension glaucoma, retinitis pigmentosa, multiple sclerosis, autoimmune diseases, and breast cancer, particularly metastatic breast cancer. This is very new. If you go for search in PubMed, you will find the publications starting with 2016 and 2017. So it's really a very, very new phenomenon described in the literature now. And here you have the list of the publication. What are the pathomechanisms for that? First of all, increased endothelin-1, very, very strong vasospasm, systemic hypoxia. This is really systemic effect. Oxidative stress, which is absolutely typical for cancer, you know, and breast cancer particularly, and metastatic disorder. Inflammation also as a prestage for cancer lesions. Hyperactivation of metalloproteinases. This is very important point because probably this is exactly the way how the brain metastases are going into the tissue after the hyperactivation of metalloproteinases. Is extracellular matrix degradation and altered expression profiles systemically. So you see the very long list of pathomechanism and a relatively long list of relative pathologies, and I would like you to think about these pathologies which have been already discovered in the relation to Flammer syndrome. So, relevance of Flammer syndrome for metastatic breast cancer. You know, my point is that we are frequently go first to very sophisticated methodology instead of to start with quite simple questions. If you think about family doctors, you know, we are also sometimes patients. So when you go to family doctor, who have asked you whether you have cold hands and feet? When you are talking with your doctor, have you been asked about that? No, absolutely not. Why not? Because actually it is very, very important symptoms for systemic hypoxic effects. So look at this. We have compared breast cancer-free subpopulation, breast cancer total, postmenopausal and premenopausal, with the question, very simple, really very simple, but describing the phenomenon of Flammer syndrome. Do you feel cold when you are not moving for a while? It's a very simple question, everybody can answer it. Do you suffer from cold hands and feet? Really very, very simple questions which, however, demonstrate. So green is our healthy, everything what is orange and red are breast cancer patient. Look at this, how big is the difference. So definitely what has been demonstrated that the phenomenon or phenotype of Flammer syndrome is extremely relevant, particularly for metastatic breast cancer. And the questions which we have put are very, very simple. It means that for looking and selecting this phenotype in the population, we can really use primary health care at the level of family doctors. So what we suggest is questionnaire. It can start very early because Flammer syndrome is typical already for teenagers, you know, slim teenagers. They're absolutely typical for Flammer syndrome. And, you know, to have brain metastasis after breast cancer with 22, it means that the lesions started many, many years ago. You know, so that's why we should go rather for teenager age, looking for this phenotype in the population and taking care of them as early as possible. So these achievements in medical sciences have been awarded by the European Association for Predictive, Preventive and Personalized Medicine. This is the historic event, and we hope that the Flammer syndrome will be really actively used in several medical fields, particularly breast cancer and metastatic disorders. Now I would like to finish with phenotyping and going to another extremely important part, namely genotyping. You know, as soon as we have localized in our subpopulation who potentially predisposed to breast cancer and metastatic disorder, what is the next step? You go for molecular profiling, liquid biopsy, and so on. So this was exactly the content of precision medicine, to go for molecular biological characteristic and to learn more about the patient. And you know, by the speech of the President Obama in 2015, that major focus have been put to the sequencing of entire population. So the question is whether sequencing is really the instrument which we can use for characterization of our metastatic breast cancer. Now, just to go a part of breast cancer, I would like to give you an example on very small population, which is also under the umbrella of EPMA, namely Iceland. So they are lucky, they have altogether 350 million. So 350,000. So it means that it was relatively simple for them to follow the dream of Americans who now want to sequence the entire population, and there are a lot of million of the USA population. So they did it already with 350,000 persons. So they sequenced the entire population, trying to make the interpretation of the data. So particularly this group, he's our representative in Iceland, and they tried to make this interpretation for cardiovascular disorders. What was the result of this? They said that sequencing alone doesn't provide any interpretation for the pathology incidence. So it is good, but it is not good enough to have full information in order to be able to treat the patient personally and targetedly. Think about the case of Angelina Jolie. So 60–70% of probability. How you can interpret it? Is it 100% or not? And if it is 60–70%, probably you should go once more for teenager age, no? To avoid the problems with potential breast cancer. So definitely what I'm going to say, that sequencing alone is not enough skill for the individualized patient profile for the patients. We need multi-omics, we need radiomics, we need proteomics, we need metabolomics additionally to sequencing. Just to sequence the population is not the solution. So to summarize this part, advancing healthcare in terms of PPPM concepts means not only genetics, but also lifestyle and environment. So all these factors playing together, coming to the result, either the patient, even with 60% of probability, either they will disease on breast cancer or not. And this is to summarize the strategy which EPMA promotes since 2008. So what we currently do in our disease care, and this is really disease care, is we are waiting for clinical onset of the disorder and then to start to react towards. So we have not too much room here to play, and it is very costly. So it is not very effective, and life quality of the patient is dropping down. So that's why all these arguments are leading us to the, okay, in 2008 it was our dream. Now we are realize that it's getting into the realization, namely that we are not operating in the down layer but in the upper layer, so that we are looking for phenotypes which could be predisposed to the pathology. We go for individualized patient profile. We try to predict the diagnosis, and then as soon as we are able to predict, we can trigger the targeted prevention. So, few words about our association. We are very strong in publishing position papers. So this is one of them, released in 2012. We published them in open access, so everybody in the world is able to read it. This was after our World Congress in Bonn, in our German parliament in Bonn. Due to this activity, we belong to the top 10% of journals in health policy. It means that people worldwide really expect us to provide recommendations in the corresponding area, and this is what I have suggested the president of ECP yesterday, that I think that we can put together our efforts and consider which kind of recommendations in terms of new trends we can provide the society with. I was happy to see the representative of policymakers here, because we need them, we need to work together, they need us for the information, but we need also them for new policy in the society. And the last slide. So as I told you, we are the umbrella of 50 countries worldwide. This year, the Congress we had was in Malta in September. Niva Shapir was there, contributing extremely well with nutritional recommendations to the Congress. So I hope to expand our cooperation, and the next Congress that we will put our efforts together before and during and after. Thank you very much for your attention.